I'm Becky Everett, Branch Secretary at UNISON Derby City Branch and a member of UNISON's National Schools Committee. Welcome to this webinar on improving air quality in schools. Over the course of the webinar, we'll be exploring the impact of polluted air on the health, attendance and performance of students and staff, and practical solutions to put in place to clean the air we breathe. The webinar is being recorded and will be available on UNISON's YouTube channel. There will be British Sign Language interpretation throughout. If you have any questions for our speakers, please ask them in the Q&A feature and avoid the chat. The Q&A feature is across the top of the screen. I'll go straight into the introducing of the first speaker, which is Dr. Binita Kane, and she's going to talk about the importance for children and adults to breathe clean air. Welcome, Binita.
Thank you very much. We could just forward the slides. So I've got my first slide. So I'm Dr. Binita Kane. I'm a respiratory consultant. Obviously, this is a topic that's very close to my heart. I'm going to just crack straight on, if that's okay, because I've got 15 minutes to cover an awful lot. So if we could just go through to my first slide. So I thought I'd just start by talking about the air we breathe. So we breathe a staggering 20,000 times a day, and that equates to about 11,000 litres of air going in and out of our lungs. So this is what sustains our life force. This is what nourishes all of our cells across all of our different body organ systems. Next slide. It might surprise you to learn that there's two layers of cells that separates us from the outside world. So if we follow the path of the air that comes in through the nose, down into the main airways, right to the end into the little alveolar sacs, and then the little box on the right-hand corner shows you that the oxygen and the gases, whatever's in the air, has got to get across one cell on the alveolar wall, one cell into the bloodstream, and then that is a highway to every single organ in the body. So this is why people smoke illicit substances, snort illicit substances, because it very rapidly gets into our bloodstream. Next slide. So what are we breathing in? Well, when we talk about air pollution, we talk about particulate matter, or PMs. And these are solid particles and liquid droplets that are found in the air. So the little yellow blob is representing a piece of fine beach sand that's about 90 microns in diameter. And then you can see there's a human hair, which is around 50 to 70 microns in diameter, just to give you an idea of how tiny these particles are. So PM10s, or particles that are less than 10 microns in diameter, things like dust, pollen, mold, are some of the things we talk about. Then we talk about PM2.5, which are smaller, and you can find those in combustion particles, organic compounds, etc. And then there's the really tiny ultrafine particles, the combustion particles that we are exposed to, particularly from traffic emissions, but from other sources as well. Next slide. And as already discussed, these travel very quickly into our bloodstream through both the upper airway and the lower airways, particularly those ultrafine particles, and they can really get into the tiny little capillaries. Next slide. So what impact does air pollution have on our children's health? So this is an infographic from the World Health Organization, and I'm not being dramatic in saying that air pollution is an invisible deadly killer. It can affect any body organ in children, and unsafe levels of air pollution can cause a lifetime of health problems. So starting with the lungs, you can get reduction in growth of lungs, reduced lung function, increased risk of developing asthma, increased risk of infections. There are a myriad of effects on the brain, including impaired mental and motor development, behavioural disorders. We have in the womb, particulate matter has been found in placenta. It can contribute to low birth weight, premature birth, infant mortality. And unsafe air pollution levels have been linked to a number of childhood cancers, including lymphoma and leukemia. And the thing that really worries me is this lifetime risk, increased risk of diabetes, heart attacks, strokes, because of the impact of air pollution on our blood vessels. And the World Health Organization estimates that over 500,000 children around the world under the age of 5 die every year from the effects of this. It's a sobering statistic. Next slide. So why is clean air important in schools in particular? Well, firstly, air pollution affects learning. So there's been some modelling done by the University of Manchester which shows that if depending on how much you can reduce air pollution in classrooms, you can improve learning anywhere between 4 and 8 weeks, depending on how much you improve the air by. So you gain learning. I haven't talked about viruses yet. I'll touch on that shortly. But if you remove viruses and other bugs from the air, that reduces sickness and reduces absences. There is a whole host of improvements in health that I've already touched on, but particularly respiratory, cardiovascular, neurological health. But there are also significant benefits to mental health for our children. And of course, we are protecting our staff as well. Next slide. So let's think about infection. If you wander out into the freezing cold, you will very quickly see your breath fogging up. So what you're observing there is the aerosols, the droplets that we are exhaling all the time as we breathe in and out. And if those little droplets contain infection, and you put 30 children in a room that's poorly ventilated with a teacher, you can imagine the volumes of droplets that are circulating around that classroom. And it's not surprising, therefore, that if ventilation is poor, that classrooms are a breeding ground for infections like SARS-CoV-2, or what we more commonly know as COVID-19, influenza, RSV, norovirus, things that kind of floor classrooms every single year over winter. Next slide. COVID-19 was a really important teacher because we were monitoring this in a way that we haven't done for other diseases, in terms of the level of monitoring that was happening in the pandemic. And you can see some data here from 2021 that showed that when the schools went back in September, there was this very rapid exponential sort of rise in infection rates in the 10 to 14-year-old age groups. And of course, that has a knock-on effect on the rest of the population, because those kids will go home and they'll be infecting their parents, their grandparents, their siblings, etc. Next slide. And we can see from the government's own data that in 2023-24, which is represented here, nearly half of all pupil absences in England were due to illness. So the single biggest cause of pupil absence. Next slide. And what we can also see is that before the pandemic, so this is data again from the government showing that prior to the pandemic, illness absence accounted for about 2.5% of all absences. And that was quite a steady figure between 2015 and 2019. If we exclude 2020 and up to 22, we can see that we haven't got back down to the pre-pandemic figures, that actually the rates of illness absence have remained higher. Next slide. And what is also concerning is the rates of persistently absent students have also increased quite significantly. They've nearly doubled to 20% compared to the pre-pandemic rate of 10%. So this is pupils who, so they're counted as persistently absent if they miss more than 10% of their total sessions. And this will, of course, be multifactorial. There'll be a few different things that contribute to this, but the increased amount of illness will definitely be a factor in here. Next slide. What about teachers? Well, the same trend is being seen in teacher illness absence. Again, government data here showing in 22-23 there was 2.6 million teacher working days lost due to illness. And again, in a similar trend to what we're seeing in the pupils, that post-pandemic, well, the kind of post-2022 figures have not reached the pre-pandemic levels and remain higher. Next slide. And this is data from the Nuffield Trust, who actually were looking at changes to sickness absence rates across public sector groups with a focus on NHS and healthcare. And this inadvertently showed that in 2021, sickness rates were higher in teachers quite significantly than in healthcare workers. I'm just going to let that land for a moment. At the height of the pandemic, illness in teachers was higher than in healthcare workers. And I think that's because teachers were heavily exposed to viruses and to COVID, and they didn't have the same protections that maybe I had working in a hospital setting. Next slide. And again, we can see that teachers have overtaken healthcare workers. So by 2021, the ONS data was showing that teachers were only second to social care workers in rates of long COVID. This is a real and devastating phenomenon. I have just written a letter for one of my patients, an ill health retirement support letter. She's a 36-year-old teacher, where I've had to state that there is absolutely no prospect of her ever working as a teacher again before retirement age, due to the fact she's been ill for 4 years and has had no progress. And this is really devastating, both for the individuals, but for the workforce as well. Next slide. Supply teacher costs have also risen, unsurprisingly, given what we've just seen. And there is often an argument made to say, well, investing in clean air is going to be very costly. We don't have the funding to do it. But when you look at the astronomical amounts that are being spent on things like supply teaching costs, £758 million spent on that in 2023-24, plus the burden to the economy for people being out of work, for people being off sick, I think the costs of actually investing in clean air will pale into insignificance. Next slide. So let's just talk a moment about the human impact of chronic infection in children. So I'm going to just briefly talk about my daughter, Jasmine, who was 10 in 2021, a perfectly healthy child, very fit and active, no health problems in the past. And she had a relatively mild COVID infection in January 2021 and just never recovered. Next slide. So the first 12 months were really quite hellish for her. She was largely housebound. She was too sick to walk any distance, requiring a wheelchair. And 4 years on, she is better. That's a long story I don't have time to go into. But there was probably 2 years where she missed out on her education through a combination of lockdown, illness, and then doing a sort of a graduated return into education. Next slide. And the last ONS figures that we've got from 2023 showed that approximately 110,000 children in the UK have long COVID. Not all of them will be as sick as Jasmine, but many of them are. And this is a word cloud from the Long COVID Kids charity, where children have described how they feel. And so you can see there are words like broken, lonely, sad, sick, trapped, hard, ugly. And I can really identify with all of these words because having lived through having a child who was in that situation, it is a really heartbreaking, it's just heartbreaking for the kids and huge impact on families as well. Next slide. This is a very powerful image that's been created by Rosie Pigeon, who's a young artist who was a child when she got ill with long COVID. And she represents herself in the middle very powerfully as being unseen and unheard. And this is how these children who are clinically vulnerable, and I'm not talking about just long COVID, this could be children having cancer chemotherapy, this could be children with bad asthma who are really susceptible to infection. It could be children who have got a relative or a family member having cancer chemotherapy, where the idea of bringing infection home is really scary for them. And these children are often trapped behind closed doors without getting the support they need to get back to school, or they do go back to school and they get reinfected. And they are in a very difficult position. Next slide. Let's not forget the beautiful Ella Kissy Deborah, who died at the age of 9 of acute severe asthma. And this was a landmark ruling by the coroner at her inquest. She's the first child where her death was directly attributed to air pollution. So she lived near a circular ring road, and she used to have to walk along a polluted route to school. And she had multiple admissions to hospital with her asthma. And each of those admissions was tracked to high levels of PM in the air and high air pollution levels. And so as the World Health Organization have already demonstrated, and as we've already talked about, unsafe air pollution can and does kill children, and it is avoidable. Next slide. So this is a report by the Royal College of Paediatrics and Child Health called The State of Child Health in the UK. And this talks about the fact the UK has got the highest prevalence, or one of the highest prevalences, of emergency admissions and death rates for childhood asthma in Europe. And the outcomes are worse for children and young people living in the most deprived areas, as they're more likely to be in built-up parts. And we know that 99% of all schools in the UK, it's a staggering figure, are in areas with unsafe levels of air pollution, as defined in terms of PM 2.5 as the World Health Organization. And 86% of schools in the UK fail all of the standards set out by the World Health Organization. So it's not surprising then that our child health outcomes are poorer than other countries. Next slide. So this isn't new information. We've known about the toxic effects of air for many, many years, since 1957, the Great Smog of London that killed thousands of people in a short space of time and led to the Clean Air Act being passed. And the headlines keep coming, and the impact and the research and the toxic effects on our children keep coming. And what we have had is a complete and utter failure to act so far and to make things safer. Next slide. So I'm just going to leave you with this thought, really, which is the potential impact of doing nothing. We could just carry on as we are, but what we're going to see is an increasing burden of chronic ill health in children and teachers, and we're already starting to see after the pandemic that that's the trend. That's going to impact, there's going to be an impact on school attendance, on learning, on education. We're going to see worsening workforce shortages in the education sector, which has a knock-on effect of increasing supply teacher costs. And then the remaining workforce, and we're seeing this in healthcare as well, starts burning out. And then you lose more staff, and then that leads to worse staff retention overall. So I'm going to finish there, and I'll be very happy to take any questions during the Q&A. Thank you.
Thank you very much. That's very, very interesting. Certainly got my brain rattling a little bit. Our next speaker is Professor Steve Griffin to discuss how viruses spread in the classroom.
Okay, thank you very much. I'm hoping that you can see my slides.
We can, thank you.
Excellent, because that was the big hurdle. Okay, so thank you very much for inviting me to this. It's a real privilege. And my name is Stephen Griffin, as just said. I'm a professor of virology at the University of Leeds. I'm also a member of Independent SAGE, as is Binita. And what I've been asked to talk about really today is just a slice of what Benita's just described to you, in the sense of, in light of the pandemic and ongoing illnesses, the real issue that we face with respect to respiratory virus infections affecting both staff and students in schools. And I've named this talk just like this as Just the Flu We Must Do It, because it's something that's irked me since 2020, in the fact that we've tried, many people have tried, shall we say, to try and, relate the pandemic to a disease, influenza, that actually still kills thousands of people every year, even though it's something that we're very much used to doing. And what I'm really going to try and get across in this talk is that we really have to, as Binita said, learn the lessons that we actually have relearned through the acute phase of the pandemic, that we can do better at controlling not only the acute threats of respiratory virus infections that present, such as COVID-19, but of course the infections that we've dealt with for many, many years, year on year, that continue to damage both child and adult health throughout the course of history. So what I'm going to try and say today, very briefly, is that we really can't stay as sort of complacent and relate back to normal as things were in 2019, because we have both our pandemic and our seasonal viruses that are still a major problem in schools and something that really have not been addressed over recent decades. I'll try and convey and dispel the myths around the fact that childhood diseases really are not trivial. Many people relate childhood diseases to adult diseases, and that's not really a fair comparison because children are very different to adults in the way that they respond and cope with disease. And when you're talking about the impacts of a virus or pollution or what have you, you need to relate that to other causes of harm that are specific to children and not to adults. And I think that's been used as a bit of an excuse really over recent history to try and not really do very much about children and the problems that they face. I'll also spend a bit of time, not much, and I can't go into huge details on every virus or every immune response that we possibly discuss in these situations, but I'll try and dispel a few myths around the way that our immunity works in relation to these things, around the best way of achieving immunological protection and building our resilience against these infections, and try and dispel some myths, many of which you may have heard in various tabloid headlines around things like your immune muscles and the myth of natural infection being a better option than anything else. And what I'm really going to try and do here is bring together the idea that we need the sorts of mitigations that we're here to discuss today, the sorts of improvements in indoor air quality, as well as part of a big plan to improve our resilience against infection as part of a multi-layered strategy that includes both our vaccination programs as well as improving indoor air quality. So I'm going to start with something slightly off kilter, and this is just really to remind us that public health is something that we rely upon without really knowing about it. Okay, so the example here I'm showing is about road traffic accidents, and it really is something that's the really primary example about the sort of thing that we need to bear in mind when we come to discuss these sorts of health problems, because the difference between understanding the risk at an individual level and a population level is quite profound. And it's the job of public health and governments and large organizations to ensure that we legislate and mitigate for the benefit of society while supporting those individuals that are most vulnerable to the extreme hazards that may or may not present themselves. So the example I'm using here is road traffic safety. We all cross the road every day, but there is a calculated risk about that. And we all know that people do die on the roads, unfortunately, something like 30,000 people a year over the course, of recent history. But we don't really bear that in mind when we go about our daily lives. And the reason that we don't have to do this is because public health and other legislation mitigates against these low probability but high impact events that happen in public health. We have anti-lock brakes, we have driving tests, we have airbags, etc., etc. We have speed limits. And all of these things allow us to go about our usual daily lives without really worrying on an individual level about these sorts of problems. And this is really what we need to try and achieve, I think, in terms of the improvement in indoor air quality, because it's something that should happen in the background. It's something that should be there that allows us to go about normal lives, bringing people into school wherever we can, making sure teachers are safe to work in schools. And so it's in there in the background and we don't need to worry about it, much as we do for road traffic safety. So this is really against the idea, which I think we've heard over recent history throughout the course of the acute phase of the pandemic, which is we either have abject freedom to do what we want, or we have restrictions, in inverted commas. And that really should not be the case. We need to do something that is in the background, helping all of us stay safe. And why do we need to stay safe? Well, what I'm trying to show you here are really the key players in terms of viral respiratory infections that we think about. There are others. You may have heard of things like HMPV recently and things, but these three viruses, influenza, respiratory syncytial virus, and of course, SARS coronavirus 2, the agent that causes COVID-19, are really the big three that causes problems year on year since 2020. And I'm showing this graph, which is color-coded for the different viruses in terms of the number of people that are put into hospital across all age groups for these viruses, to illustrate one point. And that is that this is something we have to think about all year, okay? especially now since the pandemic and the ongoing problems that we face with SARS-CoV-2. Because what you can see quite clearly here is that in the blue, influenza and the yellow, RSV, happen literally once a year, sometimes twice, but usually once a year in winter, and we call them our seasonal viruses. However, SARS-CoV-2 doesn't behave this way. SARS-CoV-2 is able to infect people because it's changing very rapidly and causes spikes of infection throughout the year and puts people into hospital. So it's something that we can't just focus on in winter. It's something that we have to focus on all year round. And this is something that's, I think, really critical to allow people to understand, because this is not something that can just happen over the course of a few months every year. It's something that we have to keep in mind until hopefully this virus starts to behave more like something that we can deal with on a daily basis. But the fact remains that actually normal, if you can see the height of this number of people that are put into hospital, still isn't actually very good. And these winter peaks of infection are predictable, they're absolutely preventable. And now, unfortunately, with SARS-CoV-2, they are indeed perennial. So we really have to do something about this as part of a multifaceted plan, and improving indoor air quality, as I'll come on to in a moment, is absolutely vital. I'm not going to dwell on this part of the slide on the left here, because Binita's already shown essentially the same data, which shows us that actually illness is a major driver of pupil absences in schools. And of course, Binita showed you data about teacher absences, etc., and illness as well. Again, this graph on the left shows that the illness shown in blue is much higher than the other causes of absences. But unfortunately, current policy from DfE, etc., is really sort of lumping all of these different causes of absence into one. And what we find in particular is children are being encouraged to attend school while still ill. People with chronic health conditions are still encouraged to attend school. And it's really not the nuance that we need to deal with the real root causes of absence, and especially causes of absence that are concerning, such as safeguarding, etc., that we need to think about going forwards. And on the right-hand side, I've shown this poster from UKHSA, which, actually gives a very positive impression about the idea of kids being ill. And this is something I really think we need to think about in some detail going forwards, because this poster, it's showing a very happy young child. It's all in green and blue, happy colours, positive. And it gives us a list of what to do when our children are unwell with various different ailments, including our respiratory viruses. But I'll come into more about this in a moment in terms of the airborne nature of transmission. But really, the message that is coming across from this poster, all of these different illnesses, is that if your kid is not actually that sick, and I say that sick because these yardsticks are always different. If they don't have a fever, for example, they're allowed to come back to school, an effort to try and redress this absence problem that we've talked about, but with no consideration whatsoever of the possibility of these children then spreading infection on to other people, in particular other children, other vulnerable children, and of course other staff and vulnerable staff members. And this is a major problem, okay? And it harks back to this idea of the population versus individual risk, as I talked about before. Because any disease, and I'm not splitting hairs between different viruses here, any disease has what we can call a pyramid of severity. The majority of cases don't cause that many problems, and you can see at the bottom of the pyramid here that most people are not detected in terms of the people who get sick with something, but there is always a sharp end of this pyramid where people experience very severe illness and death, okay? And this is a problem because a lot of the attitudes that we have towards children are that they're not vulnerable to these sorts of conditions, and that peak of deaths is really very small for them. But unfortunately, this isn't always the case. And remember, as I said at the beginning, we have to compare this to other childhood infections. So we can look at this in a slightly different way. And if we think about our population as a sort of normal, just a bell-shaped curve, where most people are doing okay in the sense that they will deal with an illness and that big hump of the curve there, and be okay. And some people do really, really well, don't get sick whatsoever. But at the left-hand side, what I've tried to show is a very arbitrary yardstick by which some people are going to develop the more severe forms of illness and some people are going to be okay. And this yardstick moves dependent upon these various factors that I've listed here. In the red, they're going to be more likely to shift that yardstick to the right. And on the right-hand side, it's more likely to shift that yardstick to the left. And that tail end of this curve is really what we're thinking about here. Because if this curve represents 100 people, perhaps we're not too concerned about the fact that we're seeing a few people down at that tail end in terms of a public health problem that we have to do something about. But when we see peaks of virus infection running into the millions of people, either in winter or with every peak that we see of SARS-CoV-2 every year, this really does become a problem because the individual risks that we perceive are scaled by prevalence. And of course, exposure, as I've tried to highlight here in red, is a major driver of this. Exposure increases our chance of developing a severe infection, it increases our chance of a severe problem, and it also wears down our immunity after a while. So you can think of immunity as an umbrella. The harder the rain's going to be, the more chance that you might actually get wet eventually. Sorry, I've lost my mouse. Where's it gone? Okay. But that graph really reflects actually just the acute issues that we perceive in these viruses. And what I've tried to illustrate here, as Benita's talked about in some detail with great personal experience, is about the long-term issues with these infections. It's not just about the acute numbers. It's not just about kids going to hospital. We know about long COVID, but there are other long-term health problems caused by these infections that have affected people over history and that we really haven't done enough about. And what this graph, I hope, shows is that long COVID affects people of all ages, including primarily, if you look at where the bars are highest, in working age people. So as Benita said, the sorts of employment that we're talking about here really does put people at risk of running into these long-term health problems. And again, it's not something that's being mitigated by our current intervention policies, whether that's to do with isolation, whether it's to do with job security, whether it's to do with long-term disability care. And as well, children do develop these problems in quite a severe way. And just to mention as well, there are these other sequelae which occur as a result of these virus infections, which are not directly the sort of classical long COVID that we might think about, but are other problems prompted, in particular, things like autoimmune conditions. And one that's really raised its ugly head in recent years is that type 1 diabetes in young children and adolescents has really increased dramatically as a result of the acute phase of the pandemic. So why is it that we think of children as being basically invulnerable to these sorts of diseases? Well, I'm not going to go into details here, but children tend to have a much more robust, what we call an innate defense against these infections. So they're less likely to allow that virus to get a head start once it infects us. And they have processes in place, things like, which you may have heard of, things like interferons and the innate immune response, which are able to suppress that virus infection such that the virus doesn't get going. And so often kids are less likely to develop severe symptoms compared with adults. And we see this in influenza, we see this in SARS-CoV-2 as well. Unfortunately, there's a kind of U-shaped risk curve where very young children are much more likely, in fact, as likely as middle-aged adults to develop these problems. But by and large, particularly primary school and secondary age school children, most of them are okay when they develop these infections in terms of their long-term health outcomes. But most is not good enough, as I've tried to illustrate in those graphs before, because if you have millions of children being infected, it translates to thousands and thousands and tens of thousands of people developing problems, and indeed hundreds of children dying, which is something that we really don't think about very much, unfortunately, and something that we really do need to remember about. And I've listed various different reasons why these differences are there in place. I can discuss those in the questions if you like, but it's very clear that those children that do not do well after infection don't have these sorts of robust characteristics. But one important point to make is that children do respond extremely well to vaccination. Just to illustrate the point further, that children really aren't invulnerable. This might be a bit hard for everybody to see, but what I hope you can make out is at the right-hand side of this graph, we're seeing a dramatic increase, and this is just showing a timeline of children mitigation measures and vaccination policies on the bottom hand corner. It's a really excellent paper that I recommend everybody looks at if you can, on the left here in the BMJ. But what I hope you can see is these peaks appearing on the right hand side, and this is the sort of timeline between 2020 and the beginning of 2022, where we shifted from Alpha to Delta to Omicron. And this also coincided with children attending schools again. And unfortunately, even though people talked about Omicron being mild in inverted commas, which it certainly is not, this actually ended up in far more hospitalizations in young people than any other point during the pandemic. So we must remember to think about this tail end of the curve every time we're considering all of these different diseases. And unfortunately, what I've tried to show at the bottom here, which you can go back and read later, is that our policies really did not keep up with the problems that we were experiencing in schools, whether that be to do with vaccinations or to do with mitigations. Now, people talk about the fact that actually it's okay to be infected because it gives you immunity. Now, this is slightly crackers because you're getting infected by something that you then want to be immune to, and then hopefully not infected again. So what I've just picked out here is a study which I think really illustrates the benefits of vaccinations rather than infections. This is a study on when the early days of the Pfizer vaccine was being rolled out in children, and it's showing two different cohorts of children. On the left-hand side, you can see that they've been vaccinated, and this graph shows their resilience against hospitalization after they've been vaccinated. And on the right-hand side, it shows the resilience against hospitalization after they've been infected. So on the face of it, you can see that blue line is much higher and doesn't decrease as rapidly in the face of time as the one on the left. So the obvious interpretation of that infection is better, as many people say, correct? Unfortunately, no. The important thing is what journey the children have to take in order to achieve this level of protection. And if you look at the people, the cohort that were vaccinated, they really didn't experience many adverse effects in terms of hospitalization or deaths upon infections with SARS-CoV-2 whatsoever. However, the children that were infected, even though there were fewer of them, many more ended up hospitalized, and unfortunately some of them died. So actually, people use this study to say that natural immunity is better. But the authors of the study actually say that we need to continue to give children boosters, because this waning of immunity, much like influenza on an annual basis, needs to be topped up in children going forward. And sadly, in the UK and other countries, that's just not happening.
2 minutes,
so last,
Steve.
2 minutes, sorry, thank you.
Thank you.
So the last thing to cover in terms of immunity is around this myth around immunity debt. You may have heard the idea that children and other people might need to be topped up in terms of their immune system by infections, but actually that's not true. Your immune system is not a muscle. It's a pre-designed, pre-programmed response against infection, against small sequences of proteins. So it's agnostic in that sense, but those sequences of proteins respond they correspond to different virus infections. And many people talk about this immunity debt as causing the major flu outbreak that happened in the winter of 2022-23, and they blamed all the COVID restrictions upon this. And many people accept that this is because there were many people that hadn't been infected and therefore immunized against influenza. And let's not forget that influenza disappeared for 2 years at the early phase of the pandemic. Unfortunately, this translates as well into these sorts of ideas around our immune system needing to be infected, translating into the idea that we should be exposed and healthy people are going to be okay and vulnerable people aren't. But actually, the reality is that what we needed to do was protect those people who hadn't been exposed, who hadn't gone through the normal damaging waves of influenza for those previous 2 years. They should have been protected with mitigations and with vaccinations. But unfortunately, we didn't really think about this, despite knowing that the virus was on its way around the world, as we'd seen from the Southern Hemisphere. So we could have got rid of this myth of immunity debt by actually establishing our vaccines or having in place the sorts of protections and mitigations that we're talking about today. And this really speaks to the fact that the idea of having multi-layered mitigations against these diseases really seems to have gone out of the window. And on the right, you can see vaccines, and you can also see mitigations, ventilation, outdoors, and air filtration. This really is our best weapon against these sorts of infections. And frankly, they're just not happening in this country. And we're talking about airborne infections. And as Binita has already covered, these infections really are important. and they're not something that is directly transmitted. It won't be solved by washing your hands. It won't be solved by the enormous mountain of perspex that we seem to waste in the last 5 years. Because actually, if you think about the sorts of diseases, not just SARS-CoV-2 or the main ones that I talked to you about, this list of diseases that the UKHSA say it's okay to come back to school with, the vast majority of them have at least a component in their transmission that is attributable to airborne transmission. So this is a major problem. And you can imagine that by reducing that transmission, the number of illness absences that we could reduce. The filtration idea is something that really does work, and I'm not going to dwell on this, but this is an example at Addenbrooke's Hospital, a very famous example. You can see on the right-hand side, those coloured dots are the detection of loads of different germs, viruses, bacteria, fungi, you name it, before they switched on air filters. On the right-hand side, what's remaining after they switched them on. And this led to a vast reduction in infections in this hospital ward, many of whom contained COVID-19 patients. So I just want to finish really by emphasizing this idea that we can't effectively protect ourselves against our seasonal infections or pandemic infections without combining these amazing mitigations that we can achieve through air filtration and ventilation with robust vaccination policies. And of course, communication as well is vital to make people understand that the risks to all of us are still present, regardless of whether or not these things make headlines. And just as a note of warning as well, we need to learn from our experiences recently, because the threat of a new pandemic is omnipresent. There is an accruing risk of influenza H5N1, but it's not the only risk by any means. And if we don't learn from the damage of COVID-19, of the 250,000 people nearly that have died, of the many millions of people who have experienced long COVID, and of course the trillions of pounds that have been expended trying to deal with this problem, then we unfortunately face the risk of going through all of this once more. So I'll leave it there, and as Binita said, happy to take any questions.
Thank you very much. Thank you. Absolutely brilliant. Both speakers were brilliant. I'm going to hand over to Rebecca, who's going to lead on the questions for Dr. Kane and Professor Griffin. Thank you, Rebecca.
Thank you very much. So the first question we've had come through, and I think that either or both of you might want to come in on this. Obviously, everyone will benefit from clean air in schools, but are there any particular groups of staff and children who would benefit most?
Would you like to go, Binita?
Yeah, I think from my experience as a respiratory physician, my clinic was full of nursery workers, teachers, people who are exposed to children in their line of work. If they've got asthma or they've got any other respiratory disease, they're particularly vulnerable. And if you think that asthma affects 1 in 12 adults in the UK and 1 in 13 children, I think maybe slightly outdated, but that's certainly the rough ballpark figure for prevalence. It's huge swathes of the population who are potentially vulnerable to repeated respiratory infection. And as I touched on in my talk, there are thousands of clinically vulnerable people around the country who their child going into an environment where they can bring infection home is risky. And that's without considering if the child is clinically vulnerable themselves. So I think there are a large number of people, and they say, don't they, that we should protect the most vulnerable, but they just seem to be a forgotten group, collateral damage almost from the pandemic. And there are lots of parents who've been forced to take their children out of school for these reasons, which doesn't seem right at all. Steve, don't know if you have anything to add to that.
Yeah, I mean, absolutely. I completely agree. Both of us work closely with long COVID kids. We work with the clinically vulnerable families, charities, and et cetera, and absolutely vulnerable people, clinically vulnerable people, have been neglected throughout the course of history, and also recently through the acute phase of this pandemic. Also, people with chronic health conditions, I think, are very much overlooked, and they do comprise many of these so-called clinically vulnerable people. But what I think I would also add is that we're all one doctor's visit from being vulnerable, okay, and it's a very easy abuse, and you see it quite a lot in various different sort of tabloidy type press. Only clinically vulnerable people are exposed to this. These people died, but they were clinically vulnerable, so that's okay. And it's kind of a platitude. But if you look at those graphs that I showed you, you know, thousands of people are dying every year from seasonal virus infections. Nearly 10,000 people died through the course of 2024 with COVID-19 on their death certificate. So this is not just vulnerable populations. What I've been trying to say through my talk is that this is a problem that we face, that we kind of tolerate because we're used to it. And now that we have the added burden of COVID-19, we've still managed to try and we've kind of normalized this as well. And we've got an added health burden to this. So I think it's something that we should be learning from and improving our status, rather than just saying, well, it's no worse than it was in 2020, so that's okay. And I think that, you know, we have to really seriously look at our vaccination strategies, our mitigation strategies, because we could do so much better than this. And that was really why I called my talk that.
Thank you. Thank you both very much. I think we've just got time to squeeze in one more question. Is that all right, Becky? So just one more that's just come in is sort of linked to that. How significant do you estimate the long-term risk of repeated exposure to COVID to be for healthy vaccinated children? Don't know if there is an answer to this one.
Well, I think healthy, how do you define that? Okay. Vaccinated children are few and far between. I think we managed to vaccinate fewer than 10% of kids prior to the vaccine program being terminated in this country. So there aren't very many vaccinated children for COVID-19 now. So that's in the younger age group, by the way. As I tried to illustrate with that study, it's not so much about the fact that the children who make it to then be exposed again aren't protected. It's about the journey that those cohorts have to take to get there. Infection is always a greater risk than a vaccination. Okay, that is a key thing that people like RFK need to understand, right? And it's something that has been proven since the 1700s, and we cannot let go of this fact. We have to look beyond the sort of limited cost effectiveness exercises that JCVI conduct, look at the broader societal benefit, look at long-term health conditions in terms of the consequences of these conditions. Think about type 1 diabetes, for example. How much money does it take to look after a juvenile who develops type 1 diabetes and then has to have insulin for the rest of their lives, etc., etc. You know, these sorts of things are not factored into the very acute perspectives of how we develop these strategies. So I think that repeated exposure as well, which I should say does give you a cumulative risk of developing things like long COVID. And of course, every time there is an infection, you roll those dice because you're not always in the same place that you were the last time you had it. And there is numerous occasions where people have had COVID several times and been fine, and then they have it again and they're really not very well. And I'm sure Binita has many stories related to that.
I won't add much to that other than to say I do have concerns about repeated COVID infections in particular, because I think that virus is doing something different to our immune systems, to our organs. And there's over 500,000 research papers now on what the virus does to the body, and none of it's good news. And as Steve says, the risk doesn't go away. If you've got away with your first 3 infections, you could still have prolonged symptoms after your 4th infection. So I think we're going to see the fallout from the pandemic for the next few decades. I think at some point COVID-19 is going to be a recognised risk factor for heart disease, strokes, Parkinson's, dementia potentially. It's too early to say that at the moment, but that's the way it looks like things are going. So not wanting to frighten the life out of everybody, but because that if you've got a normal response and you can clear the virus, that there may not be any issue with long-term problems. So I don't want everyone to go away thinking, oh crikey, but we don't know is the honest answer, and we could do something to mitigate the risks and try and prevent people getting repeatedly infected by cleaning up the air.
Yeah, and could I just add to that, even if it is a small proportion of the population that are likely to get that as an individual risk, as I tried to show in those graphs, if you have millions of people affected, every time you have a wave of this virus, that translates to many, many, many people that need to be looked after. So this chronic burden on our healthcare is something that we should be doing something about.
Thank you. The second part of that question was about masks and whether the decision to stop wearing masks was problematic and whether that was something we should be worried about. I'm aware we are running out of time for this Q&A.
A well-fitted respirator mask is protective and also prevents infection from source control. So yes, in high-risk situations, in poorly ventilated spaces, in schools, in classrooms as well as corridors, we should have been doing this much more, and we should actually try and get used to this in general every winter. You know, in Southeast Asian countries, who we can learn from a great deal, this is just normal, and they understand that this attenuates all of those things. Remember that list I showed from the UKHSA poster, which sadly now includes measles and mumps? You know, these are airborne infections. Masks work against all sorts of things, not just SARS-CoV-2.
I would also say that if we cleaned up the air, then it reduces the requirement. You know, you think about the Swiss cheese model, but it reduces the requirement, because no one really wants our children to be wearing masks in school. It's not something we'd want for our kids. But in the absence of anything else, perhaps that's what we should have done. But I think that's another whole topic that might need another webinar.
Well, thank you both very much. Thank you. I will pass back to Becky. Thank you.